Everyone, welcome. Thanks so much for joining us for this virtual UMiami Health Talk. Living with Endo, real talk on pain, pelvic health, and healing. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by the UHealth Comprehensive Women's Health Alliance. The mission of the Women's Health Alliance is to provide cutting-edge, comprehensive women's health services to women in our community. The goal is to keep you healthy and happy by connecting you with essential preventative and women's health-focused services, while also simplifying the complexities of navigating the healthcare system. To learn more about the UHealth Comprehensive Women's Health Alliance, visit umiamihealth.org/women's health or call 855-349-6636 to schedule a consultation. I know you've seen it on your screen. We're going to show it to you again at the end, so don't worry. The information will be available to you throughout the evening. So tonight, our esteemed panel of experts will delve into one of the most perplexing topics in women's health, endometriosis. We're going to cover real experiences of those living with endometriosis, how endometriosis is diagnosed, and why early detection is critical, advances in managing chronic pelvic pain and inflammation, surgical and non-surgical treatment options for long-term relief, and the connection between endo and pelvic floor health. Our presenters tonight are Stephanie Delgado, MD, Assistant Clinical Professor of Gynecologic Surgery; Morgan Sendishu Shane, MD, MSTCI, Director and Founder of the UHealth Comprehensive Women's Health Alliance; and Andrea Wood, PT, DPT, PhD, Board Certified Women's Health Clinical Specialist, Certified Pelvic Rehabilitation Practitioner, and Assistant Clinical Professor of Physical Therapy. Now, after their presentations, we're going to begin the Q&A session. Now, this is a unique opportunity for you to ask direct questions of our experts. Don't miss the opportunity. You use the Q&A feature at the bottom of your Zoom screen, which you can locate now. Take a look at your laptop or phone, and that's where you're going to enter your questions, and I'll tee them up for our experts. So it's my pleasure to introduce our first speaker, Dr. Stephanie Delgado, an Assistant Clinical Professor of Gynecologic Surgery. She uses minimally invasive and other innovative surgical techniques to treat conditions including endometriosis, fibroids, cysts, and other gynecologic conditions. Let's welcome Dr. Delgado.
Thank you so much for that introduction. Welcome everyone for this talk that I am very, very proud of that we're all here doing today. So let me just share my screen. And can everyone see? I'll take that as a yes.
Yes, we can.
Awesome. Okay, so first let's start off by saying what is endometriosis. So endometriosis is a chronic pain condition. So I don't like to think of endometriosis as something that you go for surgery, you cure it, it's over, you're done with it. I'd like to think of it as a chronic condition because it affects so many women for such a long period of time. Really, it affects about 1 in 10 women, about 10% of females, most commonly around 25 to 45 years old. That being said, I've had patients who are 13, 14 presenting with endometriosis symptoms, and I've had patients who are postmenopausal presenting with endometriosis symptoms. So it can really be variable. What it is essentially that there are endometrial glands that are supposed to be inside the lining of your uterus that have gone outside. And so you get these little implants that are foreign, that are not supposed to be there. And what your body does is it fights them. It causes a lot of inflammation, a lot of scarring, and it causes a significant amount of pain. And so usually we see it confined to the pelvis. So that's the uterus, the fallopian tubes, your ovaries. When it can form cysts on your ovaries, and that's called endometrioma, or a chocolate cyst, is the most common. It can be inside the walls of your uterus, and that's called adenomyosis, which it comes along with endometriosis as well. And it can be on your tubes, causing issues with fertility, and it can be in other organs too. So although it's more rare for it to spread to other organs, it has been found in the bladder, in the rectum, in the bowels, in the appendix. I've had patients that have it in their lungs. So it's something that can really spread, although that's not really common. What causes it? So really there hasn't been a ton of research to tell us exactly what is causing this, right? And so what the leading theory is something called retrograde menstruation, which means that when you have your period, some of that blood goes backwards through your tubes, And that's how those cells get implanted there. One of the other theories of adenomyosis, or when that endometriosis is in your uterus, is with birth, right? With birth, there's a lot of stretching of the uterus. There's a lot of communication of the inside lining with the walls, especially if there's a C-section. And so that's how those cells can migrate. That being said, there are a lot of cases and a lot of patients who don't have the clinical, it doesn't really fit this picture essentially. So we know there's a lot of autoimmune issues that are connected with endometriosis. We know there's a large genetic component as well. So I think it's really multifactorial in how it presents. So how do I know I have endometriosis, right? So what the biggest signs of endometriosis are pain, and pain that is cyclical, or pain with your period. So a lot of women will have pain the week leading up to your period, and then the first 2 days is kind of what I mostly hear, but it can also happen right after the period or during ovulation, so mid-cycle, that you get severe pain. And what I describe, or what I like to tell patients, is it's not normal for you to have to go to the emergency room because your pain is so bad. That is not a normal period. A normal period lasts 4 to 5 days. Yes, it's uncomfortable. Yes, you have bloating. You take some Advil, you can go along your day. Once it starts becoming something that is affecting your quality of life, you're laying curled up in bed with a heating pad and you can't move, you can't go to work, you can't go to school. That's when we have to start thinking about endometriosis, because for people to tell you that's just a period, that's not true, right? I've never been to the ER for my periods. So it's something to really think about. Like, if your pain is that severe, that's when you should start thinking about this disease. Other things that are associated with endometriosis, so heavy bleeding. So that comes along with when that's in the walls, that adenomyosis. It's heavy bleeding with your periods. And what that means is, like, you soak through pads in an hour, you're having to constantly change your pad, your tampon, or your cup. And it's more than it can cause even up to anemia as well. The more classic signs of endometriosis are pain with bowel movements. So I've had patients describe it as, when they have their period, it feels like someone's stabbing them in the bottom because of the pain, or they pass out from the pain of bowel movements. And like Dr. Shea, we'll talk about the issues with diarrhea and constipation also associated with endometriosis. Other signs are pain with intercourse. So this could be with initial penetration, deep penetration, to a point where you don't want to have sex, or sex is not enjoyable because it's so painful, right? Those are signs of endometriosis as well. Endometriosis has been linked with infertility, and so about 20% of women will struggle with difficulty getting pregnant, and that can range from have a bunch of different meanings, whether you need extra time, some help, or IVF. And so it's something, when you have endometriosis, to think about, or when you're going down the rabbit hole of infertility and getting pregnant, if you're having issues and no one can figure it out, and you also have been always dealing with these heavy, painful periods your whole life, endometriosis is probably playing a role. And so how do we diagnose it? Endometriosis is classic for being like one of the hardest things to diagnose. On average, it takes 7 to 8 years for a woman to get a diagnosis, which is ridiculous. One of the studies that has quoted that they've visited over 10 doctors before even getting someone explaining endometriosis or thinking about endometriosis, right? And so if this is you, like, thinking about, have you gone to the emergency room with this severe pain that no one can figure out what it is? Like, they do imaging, nothing comes up. They say you're fine, it's just your period, right? That's not normal. That's when we should be thinking about this. When I'm talking to patients and they're describing the symptoms that we just talked about, that's when I bring it up. That's when I bring up endometriosis. A lot of it is based on your symptoms, right? We can be suspicious for endometriosis, and we can start treating you for endometriosis without having a tissue diagnosis, or without having the firm diagnosis, because it presents like this in a lot of women. What we do to how do we look for endometriosis in your pelvis, essentially? So imaging is not that great. So ultrasounds can be negative and you can still have endometriosis. Ultrasounds are really good for looking at cysts on your ovaries. So if you have endometriosis cysts, you have endometriosis, right? It has that diagnosis. but it's not really good for picking up smaller lesions that are usually the culprits of a lot of the pain. MRI has been a little bit better in detecting it in terms of looking for more deeply invasive endometriosis, or what we call endometriosis when it gets close to the rectum or close to the bladder. But again, it's not perfect. And I've had multiple patients that have chronic pain, have had negative ultrasound, negative MRI. No one can figure it out, and we do a diagnostic surgery, and we find that they have endometriosis. And so that's really the gold standard for how we diagnose, which is surgery, looking inside your abdomen and taking a look for the classic lesions of endometriosis. So not only does that help us diagnose, but it also helps us treat as well. And so let's talking about what are our options for endometriosis, some of the non-surgical things that we deal with, right? Regulating your menstruation is going to be number one. A lot of, we're going to go into a little bit more detail about birth control, but if we're thinking that that endometriosis is being flared by changes in your hormones, by your menses being heavy, having a heavy menses, right? Controlling how heavy your period is and controlling you even getting a period is because what's going to help. Other therapies that help are really lifestyle modifications. So diet plays a huge role, not only in your gut health, but also the inflammatory aspect of it, right? An anti-inflammatory diet with endometriosis is going to be the best thing that you can do. And what that means is limiting processed foods. Like I'd like to think of it like limit things that come from a box, try to eat as whole as possible. And some people have to eliminate gluten as well, and have had good results with that. Other things, diet, yoga. I mean, besides diet is exercise, yoga, um, Pilates, weightlifting, all have been helpful as well. And then when looking at other modalities that are not as not provided by us, but have helped with pain is acupuncture. Acupuncture is a great thing to add on to help with chronic pain as well. Dr. Wood will be talking about pelvic PT and how that plays a huge role as well in endometriosis and our management of it. And I'll tell you, I send all of my patients before, after surgery to pelvic PT because it's just so important in your pelvic health and in the muscle component of pain. And then when thinking about how you've gone 8 years with this pain, no one's diagnosed you, everyone's told you that you're crazy or that it's in your head or this is just a normal period, that's going to play a toll on you, right? There's no way that you get out of that without any kind of medical trauma, without any thoughts about are you, like, you second guess and you think, am I crazy? Am I making this up? Because everyone's gaslit you and everyone ignores you. And so the mental health aspect of this is so important as well. So also combining cognitive behavioral therapy and therapy in general helps you deal with all of the medical traumas that come along with this. Hopefully we'll minimize those in the future, but being in pain is something that will really take a toll on you. And so let's talk about birth control, right? And so there's a lot of thoughts about birth control out there, where depending on where you get your information from, TikTok, Instagram, wherever it is. But birth control helps, and it doesn't help everyone, right? And this is a very generalized view as to how we manage endometriosis. And I'll tell you, we look at each individual patient and tailor their management based on you as an individual, and not here just take birth control. We take a lot of things into consideration. And so birth control helps because we take it to stop your period and stop those big changes in your hormones, right? And so that's going to help you bleed less. It's hopefully going to stop your period so you don't get that backward flow. And for women with endometriosis, sometimes you get a lot more side effects to the combined birth control, which is like birth control with estrogen and progesterone, which is the classic kind. So my tendency is to start on a progesterone only method because estrogen is so much more dominant in endometriosis. So we are kind of balancing out a little bit better. Other non-pill forms are an IUD. So I recommend the Mirena IUD as opposed to the copper IUD that has no hormones. And the reason behind it is that we need those hormones to help with the bleeding and to help decrease it, right? And so the IUD goes inside the uterus, and what it does is it secretes locally in the uterus to help you not bleed as heavy and to help with some of those pain symptoms as well. The IUD is actually one of the better things in terms of medical management that we have for adenomyosis, or that when the walls of the uterus become thicker. Um, and then other like more aggressive medications that we use are Orlissa or Lupron. And what these are medications, pills that essentially mimic menopause. And so what they do is they shut down your ovaries so that you're not ovulating and you're not releasing all of those hormones. And so they work really, really well for some women to help with the pain symptoms. However, it can cause a lot of those side effects of menopause. And so a lot of people don't like taking them because of those bothersome side effects. In addition, they can only be used for a short period of time, about 2 years for Alyssa. And again, this is all general. Everyone responds to medications differently. Everybody responds to different kinds of birth control differently. And so we really have to try and tailor it based on you and what your side effects and what your history has been, really. And so when thinking about chronic pain, we also have to take into consideration something called central sensitization. So what that is essentially your neurons have been firing constantly because you've been in so much pain. And so you have an altered way of sensing pain, like your neurons have had created this. It's not in your head. We see this with a lot of chronic pain syndromes like cancer pain, fibromyalgia, and endometriosis. And so not only addressing the endometriosis from the organ period standpoint, we also want to address it from that nerve standpoint, right? And so the way we do that is with certain medications like amitriptyline and duloxetine, which are two different medications that have been used for this and are longer term medications that we give to help kind of like just calm down the nerves and help you reprocess that a little bit better. Again, the cognitive behavioral therapy is also another wonderful addition to your therapy because it'll help you respond to the pain. It will essentially enlighten you in how you respond to pain stimulus, and it will help you kind of manage that. And I think it's important for all women to be in some kind of therapy as well. And so when should you consider surgery, right? Surgery is not without its risks, right? And so we take it seriously. We take it seriously when we should consider surgery, right? What I tell my patients is that one, when the medications aren't working for you anymore, we should consider it. It's becoming something that's affecting your daily life, right? So if you can't take your kids to school, if you can't have sex with your partner, if you are missing work and are miserable and can't go out with your friends because you have to plan your life around your period, that's affecting your quality of life, right? That's affecting your ability to function in normal society. I think that the benefits of you getting surgery far outweigh the minimal risks with surgery, and that's when we should consider it. Other reasons are doing surgery is when you're struggling with infertility. So there's been research that shows that doing surgery for endometriosis helps women who are struggling with infertility to improve pregnancy outcomes and to improve your chance of conceiving naturally and maintaining a pregnancy, not only naturally, but also with IVF. And so it's something that we think about too. If you've been struggling with infertility for a long time and you've been having endometriosis symptoms, thinking about doing surgery around the time of considering pregnancy, and that benefit lasts for about a year after surgery. And so what does the surgery look like, right? So usually it's minimally invasive. And so we can do it either robotically or laparoscopically. It's done through small incisions on your belly, about 5 millimeters. So it's like that big. And through there, we take a look inside, right? We're looking for endometriosis lesions. The way I do surgery is we take a look all the way, liver, diaphragm, stomach, small bowel, large bowel, appendix. So we're looking at your entire abdomen. And then we focus on the pelvis, like we had said before, is where most endo tends to be. And so what we do, we look for it, we look for the lesions of endometriosis, and we excise it. So excision surgery is the gold standard, not ablation. So what ablation means is you're burning those cells or you're burning the spots of endometriosis. Excision means we're cutting that all out. The reason why excision is better is because you can get the whole root of the disease, right? Ablation, it'll just kind of grow back faster and it'll grow back right on top of where you just were, or it could be a tip of the iceberg where you're just seeing the tip, but the lesion goes deeper. And so what it looks like there are a lot of different ways. Here on the right, you can see a picture from surgery of those black dots. That's the classic look of endometriosis. but it can be like white dots, red dots. It can cause changes in your peritoneum or in the lining of the inside of your organs that causes a pulling look or causes holes, and it can just distort the anatomy and how your organs sit in there. Um, so when it goes into the walls of the uterus, like I've mentioned, it's called adenomyosis. That means your uterus is a little bit bigger or boggier than normal. And that causes pain, and that also causes heavy bleeding. So that combo of that pain and heavy bleeding with like passing large clots and things like that, you should be thinking adenomyosis. For for that, really the best treatment is going to be eventually a hysterectomy. Doesn't mean that if you've never had kids and you're young and you have adenomyosis, you need that, but it's something that is going to be more definitive, right? A hysterectomy helps because we're taking out that endometriosis that's inside your uterus. A hysterectomy also helps decrease the chance of endometriosis returning. Um, that being said, I've had patients come back with after a hysterectomy and it's still recurrent. So it can come back still with a hysterectomy, but it significantly decreases that risk. And so it is a big decision, getting a hysterectomy, and I don't want to minimize that in any way, shape, or form. But a lot of women, when they have a severe endometriosis, it's already in the walls of your uterus and it's already on your uterus. And so a hysterectomy is going to give you more longer term relief and more reduction of your pain symptoms. And then so life after surgery. So it can be that you get out of surgery and you already feel better. I have a lot of patients tell me like the recovery was easy because it was nothing compared to my normal pain. Or it can take a few months, right? It can take a few months for your body to heal and for your body to get back into feeling the full effects of the surgery, right? Everybody's body is different. Everybody responds to surgery different. Everybody's endo is different. And so don't compare yourself to what you saw online. Don't compare it to yourself to your friend. You just have to see that every day is getting better, every month is getting better, and you're feeling improvement. And for some women, it takes longer. About 90% of patients are pain-free after an excision surgery at 3 years. This is not including hysterectomy. Hysterectomy, that year span is longer. But with excision surgery, about 90% are pain-free at 3 years. Again, this is a generalization. There are patients that have really bad endo that keeps recurring and is faster than that, but on average is about that. And so what increases your risk of it coming back, right? It depends on how bad it is. It depends on the stage. So endometriosis is stage 1, 2, 3, and 4, and that's based on where it is in your abdomen. So the more severe stages is more likely for it to come back. If you have an ablation, it's more likely for it to come back than if you have an excision. And then if you remove your uterus and your ovaries, it's less likely to come back. In my practice, I'll say I don't routinely remove an ovaries at the time of hysterectomy because a lot of the women that I'm taking care of are in their 30s and 40s getting hysterectomies, and we still need those hormones for your bone health, for your heart health, for your brain health. And so removing your ovaries would put you into menopause, and yes, sometimes it's indicated, but on average the majority of women I will leave the ovaries to help with all the other things that can come with early menopause. um and overall surgery, like I mentioned, does improve your chances of successful pregnancy and fertility treatments as well. And so if you're suspecting you have endometriosis, we're here to help, right? One of the biggest things that I always tell my patients is that you're living with pain isn't normal. Even if it's been your normal for years, right? It is not normal. It is not normal to be a slave to your period, right? It's not normal to live your life around your period. And so we're here to help and answer any questions, and that'll be the end of my talk.
Thank you so much, Dr. Delgado. Super informative. Let's tee it up now for our next speaker, Dr. Morgan Sendishu Shane. He's the director and founder of the UHealth Comprehensive Women's Health Alliance. She's a gastroenterologist and digestive health expert in motility disorders. She also has a particular passion for making preventive and specialized health accessible and simplified for women to navigate. Hi, Dr. Shane.
Thanks so much, Ileana, for that nice introduction. And Dr. Delgado, what a great start. We're so grateful for your presence here and for all the care you provide for the women here for us. I am going to be a little bit more brief to give the opportunity. I'm just going to share like this to give an opportunity for the to really showcase the other providers who are more on the front lines of this very difficult to manage disease. But we are a multidisciplinary team, and I'm going to tell you a little bit more about the gastroenterologic aspect of this disease. So what about bowel habits and endometriosis, right? There's natural variation in bowel habits with menstrual cycles in just about everybody. During the time of ovulation, it's normal to get a little bit more constipation, and it's normal to get looser stools around menstruation. That variation is completely physiologic. The problem is in patients with endometriosis who either have prolonged menstruation, irregular periods, more frequent menstruation issues related to ovulation, these swings can be more severe, leading to more severe constipation and more prolonged episodes of diarrhea. A lot of people come to my clinic telling me that they have IBS and also difficult periods. That's very possible. Many people have both of those things, but it's also important to consider endometriosis as well in the differential. And while the true diagnostic criteria for IBS is based on this Rome criteria, where you need to have recurrent abdominal pain at least 1 day a week, in the last 3 months associated with at least 2 of the following criteria, including it has to be related to defecation, meaning it either gets better or worse going to the bathroom. It's associated with the frequency of the stool or a change in the form or appearance of the stool. So either looser stools, harder stools, difficulty with defecation. And so while many patients with endometriosis also meet criteria for IBS, the cause may in fact be primarily related to the endo itself. These patients, as Dr. Delgado aptly explained, have this visceral hypersensitivity, this central sensitization, where they have chronic abdominal pain, primarily related to their endometriosis. But with using this IBS Rome 4 criteria, you might actually meet criteria for IBS, but the source of the abdominal pain is the endometriosis rather than this disorder of gut-brain interaction that we manage primarily in irritable bowel syndrome. And again, you can also have those hormonally mediated, wrong direction, the hormonally mediated changes in bowel habits, which could give you this variation they're describing in IBS. So it's important to really get a good handle on the frequency of symptoms, how it relates to your cycle, and anything else that might be appropriate. The good news is it's not your responsibility to decide what's important and what's not. That's for us to take care of. Your job is to just tell us a good story and to let us figure it out. So with that, how do we figure it out? There's limited utility for extensive testing and diagnosing IBS. Based on the Rome 4 criteria, there is a positive diagnostic strategy. You do not need to have a $1 million workup or an extensive battery of tests to prove that you have something that meets very specific criteria. If you're presenting primarily with diarrhea, there are some basic stool tests we'll order looking for inflammatory markers in your stool. Sometimes we're looking for blood inflammatory markers. This is not for something that happened, for a handful of weeks. These are usually chronic symptoms. And so we're not really checking for infections and other things because it's unlikely to be something that plagues you for the 7 years that you've been looking for, help for your condition. Similarly, if you have constipation, sometimes some additional pelvic imaging might be helpful if it's not yet completed. Oftentimes patients will get CT scans before we've even seen them because if their symptoms are so severe, chances are they presented to the emergency room and got an imaging there. And so we're able to get that. But in general, we don't really need a lot of imaging from an IBS, GI, endometriosis related standpoint. So how do you treat the abdominal symptoms as it relates to the endometriosis? There's a lot of different approaches here, as Dr. Delgado had mentioned, but the most important thing is to either get the endo diagnosed or under control. If you have a known diagnosis of endometriosis and you know that your symptoms are worsening, I'm always going to recommend that you make sure that your endometriosis is in fact appropriately controlled, and that's where you partner with your GYN provider, you have a multidisciplinary team of care providers who can make sure that everything's being, all the I's are dotted, the T's are crossed, that levels haven't changed, that no new endometriosis has developed from prior surgeries, that your hormones are appropriately suppressed. We want to mitigate contributing lifestyle and dietary triggers. There is a lot of, for lack of a better word, non-nutritive items in our foods. That includes non-nutritive sweeteners. Those are sugar alcohols like inulin, ribulose, sucralose, xylitol. There's a lot of preservatives and emulsifiers that are in our foods, especially those that come in packaging, as Dr. Delgado had said, that can lead to a lot of other additional symptoms and really kind of do unfavorable things to our bowel habits. Excessive lactose, about 70% of the population is lactose intolerant. That happens with age. That is physiologic, but certainly a diet heavy in lactose, that if you have additional bloating and unvariable stool patterns, that would be something to evaluate. Also, poor sleep has a significant effect on circadian rhythms, which in large part dictate a lot of our bowel habits. And what I always tell patients is to manage the predominating symptom. So if your issue is that your stool consistency is unfavorable, that's what we're going to tackle. If it's abdominal pain and there's central sensitization or visceral hypersensitivity, there are many medications that we can use to treat that. And as Dr. Delgado had referenced, it's really important to address the psychological burden, because especially from a GI perspective, irritable bowel syndrome is a disorder of gut-brain interaction, meaning that the same neurotransmitters controlling your brain and your mood, which are dopamine and serotonin, have receptors in your gut, and they can affect how your gut moves and how your gut feels. And so we want to make sure that we are maximizing all the available angles to treat this difficult to treat disease. And that brings me back to what I originally said, which is that we really need a multidisciplinary care team with a whole patient approach. That's why you have 3 different providers on this webinar today, because we all work extremely closely together. There's lots of other opportunities, like we said, including psychology and psychiatry, dietitians. The goal is to improve your overall quality of life. And if we can chip away at all of the different angles just a little bit and overall improve where you are in your life, then we all take that as a win. And with that, I'm going to transfer now back to Ileana.
Thank you so much, Doctor. And thank you all in the audience who are very motivated with your questions. We see that the Q&A box is lighting up, and our experts are going in there to try and answer a few of them, as many as we can get. But keep bringing them in, because they're super interesting. Now, our final speaker is Andrea Wood, who earned a PhD in physical therapy and board-certified women's health clinical specialist with specialized training in pelvic health disorders. She's lectured both nationally and internationally on pelvic health-related conditions. Welcome, Dr. Wood.
Thank you, Ileana, for that great introduction. I'm going to share my screen, but I am so excited to talk to everyone tonight about pelvic health physical therapy, because a lot of individuals don't even realize we exist. They don't know what a pelvic health physical therapist is. But when it comes to endometriosis, we really are the partner that you really need in your medical treatment. So what is a pelvic health physical therapist, and what exactly do we treat? So we treat the muscles of the pelvic floor, but we also treat a lot of the surrounding musculature as well. And one of the things I love to tell my patients is hips core, functional pelvic floor keeps you out my door. So they all have a symbiotic relationship around the pelvis. And a lot of individuals don't even realize they have pelvic floor muscles, or that there's multiple muscles within their body. So the pelvic floor muscles are a group of 3 layers of muscles within the pelvis. They have to contract well, but they also have to relax well. And this is where I see a common problem with endometriosis. So there's a big misconception that patients are going to come to pelvic health physical therapy and we're just going to do a bunch of Kegels, which, as you know, is just when you contract the pelvic floor muscles and relax them over and over. But a lot of times when you come to pelvic health physical therapy, we actually teach you how to relax the muscles a lot. And so often with endometriosis, we see an issue with this, partially to where the disease might be located, but also in response to chronic pain. So similar to how someone might tense their jaw or tense their shoulders in response to pain, staying tensed in the pelvic floor muscles is a very common response to chronic pain. And so I compare that to tensing your bicep all day. If you kept your bicep tensed all day, it's not going to feel good, and it's also going to feel sore to touch. So these are some of the reasons why we tend to focus on relaxation of the pelvic floor muscles with endometriosis. And the pelvic floor muscles are very important to your overall function, and they serve 5 functions. And I always say, remember the 5 S's. So not only do they help control pee and poop and push poop out, they also help with our sexual function. They support our pelvic organs like our uterus, bladder, and rectum, almost like a hammock as part of a larger stabilization system. They also stabilize our pelvis, hips, and back as part of our musculoskeletal system. So it is not uncommon when you come to physical therapy for your pelvic health that we're doing a lot of stretching of the hips, stretching of the abdomen, but also strengthening of the core and the hip musculature as well. And they also serve as a sump pump, so they assist in the movement of fluid up and down your bodies as part of the overall blood and lymph system. And so, as pelvic health physical therapists, we have specialized training in pelvic health to address the muscles of the pelvic floor. And just like physical therapists that help with your knee pain, your back pain, pelvic health physical therapists help with issues that are often very private and hard to talk about and commonly misunderstood. But a lot of these issues are very treatable. So, again, I help with the medical team to help treat your constipation, help treat your urgency of urination, help treat the painful intercourse that you might be experiencing. The way that we do this is by optimizing your pelvic floor muscle function. And so these are just some examples, and we're going to go into more detail about what we do. But as you can see here to the right, we have a picture of something called biofeedback therapy. That is where you see your pelvic floor muscles on the screen in forms of different images. That helps to train the coordination of your pelvic floor muscles, especially for individuals who might not even realize they've been tensing their muscles and they don't even know the difference between contracting and relaxing. And then as you can see lower on, we do a lot of strengthening. So there's an example of me doing a core exercise. And then we also work on manual therapy as well. And so the common pelvic health issues that relate to endo that I just recently touched on was, like I said, the difficulty relaxing of the pelvic floor muscles, the pelvic floor muscle incoordination too. So if you've been chronically tensed in response to pain, or based on the location of endometriosis, there might be restrictions that are causing you difficulty to contract your pelvic floor muscle as well. We help to retrain all of that. Also, we help treat abdominal pain, which is related to the musculoskeletal and visceral system. We treat the low back and pelvic pain, which has a variety of contributors, along with the endometriosis. And then we help you regain your fitness and your overall condition. Because a lot of times when you're going through this chronic disease and it's been many years for you, you lose a lot of fitness. So one of my primary goals for my patients is to restore them back to their overall active self, because exercise is so important for our well-being, and being active and feeling capable to do the physical task that you need to do throughout the day is so important for your overall quality of life. So a lot of individuals also ask, well, what happens during an evaluation? What should I expect with pelvic health physical therapy? Because often they might be familiar with maybe going to physical therapy because they tore their meniscus in their knee or they have an ankle sprain. But there's a variety of things that might happen during an evaluation, and you might come to us where you're symptomatic, but you're not really yet diagnosed by an MD. So, an example, as Dr. Sendishu Shane gave, was you might be diagnosed with IBS by another doctor. This is where the Women's Health Comprehensive Alliance comes in, and we often can refer you then to a doctor within to try and get some additional screening for you. Some patients come to me pre-operatively, which is really great because we can start working on some issues that you might have prior. So we start teaching you how to relax your pelvic floor muscles ahead of time, how to coordinate those pelvic floor muscles. We teach you stretches to do after surgery. There's a lot of things that we can do to also prepare you for that immediate post-operative period. And then a lot of patients come to me post-operative too as well. So we might be evaluating your abdomen, evaluating the pelvic floor muscles once we get medical clearance from the doctor, taking a look at the overall strength of your hip and your core muscles. So during an evaluation, we're looking at different things depending upon what stage you might be at. And then sometimes what we may do is something called an internal pelvic floor muscle assessment. That is when we assess the function of the pelvic floor muscles. So how strong are they contracting? How well are they relaxing? Are there any painful points within the muscles? How long can you hold a contraction? Are you able to contract in response to a situation like a cough, sneeze, or laugh? These are all things that we may evaluate. I always tell my patients, you don't have to do an internal pelvic floor muscle assessment on day one. We work with you and we do it when you feel comfortable with us as a provider. But I always tell my patients it's really important to get in early. So you might think, oh, I don't need to go to pelvic health physical therapy until after my operation. I always encourage, come see me for some sessions before you get operated on, because again, there's a lot of things that I can teach you and that us as pelvic health physical therapists can do to help prepare you for after surgery. And so another common thing that I hear is that a lot of individuals might say, oh, like I don't need to go to a pelvic health physical therapist. I went to this place where they said that they have some experience in pelvic health, or my Pilates instructor said that I'm doing pelvic floor physical therapy. It is important if you have endometriosis, which is a can be a chronic lifelong disease for some, that you find someone who has a specialty in pelvic health and that they're a physical therapist who has been practicing pelvic health for a while. And that also includes internal assessments as well. So we really do have specialized training, and it's not general advice, hoping just a dart sticks to a board. Just doing a bunch of exercises you might see on TikTok or Instagram. Sometimes that one size fits all doesn't apply to someone when they have a specific presentation. And similar to what Dr. Delgado said, is endometriosis can have a different presentation in different individuals. We really do also give you that hands-on treatment, especially post-operatively too, to help improve muscle guarding and overall tissue health. And this gives your nervous system a sense of safety. It helps with pain sensations, and it helps retrain that nervous system, something that feels good in that particular area. We also give you one-on-one coaching about what you're doing with your pelvic floor muscles during activities. So an example I like to give, let's say you have endometriosis and you're someone that enjoys weightlifting. Post-operatively, when you're able to and cleared a couple months later, we might teach you how to use your pelvic floor muscles more efficiently as you're weightlifting. So again, working with you and what the task you do that you enjoy doing is something that we're specially trained in versus just giving you general advice. So again, here are some common treatments. Again, to my right, what you'll see, this is a picture of a rose. That's an example of biofeedback therapy. I tend to use this setting when I'm treating someone with constipation and retraining their muscles how to bulge and relax in order to pass a bowel movement efficiently. Sometimes we also do something called internal manual therapy to the pelvic floor muscles, especially if they are tight. So we work on stretching of the pelvic floor muscles to restore that normal length tension relationship. So similar to if you go to a physical therapist who works on your bicep, again, physical therapists also work on the internal pelvic floor muscles as well. And what you can see here, also the lower screen, is something called dilators and a pelvic wand. A lot of times we use this type of medical therapeutic device to teach you how to stretch your own pelvic floor muscles at home. And this can be something that can be very beneficial, especially prior to intercourse too as well, if intercourse has been historically painful for you. It also can just help with general pelvic pain symptoms, back pain, hip pain, especially if there's a contribution from the pelvic floor muscles. We tend to do a lot of manual therapy too as well to the abdominal wall, the back, and the hip musculature, trying to, again, restore that normal leg tension relationship. We'll usually follow that up with exercises to help you manage some of those symptoms at home. We focus on nervous system down training because again, when you've been in chronic pain for so long, we want to help to facilitate that calming of the nervous system to help decrease pain sensations. So an example of something we might teach you how to do is diaphragmatic breathing, which can help with that sensation of pain too as well and calming of the nervous system. And then we do hip and core strengthening over time while we monitor your symptoms, depending upon the stage that you're at. So whether you're preoperatively, this can help make it an easier recovery on the back end, or if you're just trying to restore your normal function postoperatively, we follow you throughout that journey for a couple of months. And another large piece that we do is education. And education is really crucial for self-management. So when patients come to us for pelvic health physical therapy, our goal is to always make you feel like you have the power in order to also help yourself. So it might be toileting techniques that we're having you do, educating you about toilet posture, certain breathing techniques we want you to do on the toilet while you're trying to pass a bowel movement, teaching yourself to not ignore signals within your body to pee and poop. So that's why you see in the right-hand corner here, I'm so busy, I only have time to tell people how busy I am. So teaching you to listen to those signals of your body when you have to go to the bathroom, relaxing on the toilet. In the lower left-hand corner, you see a picture of cafecito here. So teaching you about what bladder irritants are, if you're having a lot of frequency of urination, teaching you those lifestyle factors of balancing out bladder irritants with proper hydration, teaching you proper lifting techniques too, as well, and how to move throughout your everyday that might decrease pain sensation or decrease pressure on your pelvic floor. And then also giving you advice on what I like to call therapeutic medical devices. So in the lower right-hand corner, as you see these three rings around a finger, this is a device that helps control depth of penetration for intercourse. So educating you on what devices are available in order to help you return to your prior level of function is something that can be very helpful for you to have knowledge on. And I always tell my patients, it takes time. So when you come to pelvic health physical therapy, a common misconception is, well, if I got my excision surgery, all my pain is going to be gone post-surgical. It's a journey. If you've been in chronic pain for a prolonged period of time, we're going to be doing a lot of nervous system downtraining, trying to work on rewiring some of those pain signals to your brain in order to teach your body that it's safe to move again and safe to do these activities that you really love to do prior. So a lot of times, like Dr. Delgado said, those nerves become overly sensitized as a protective response, even when the nerves in the surrounding tissue have healed. And to the right, this is a book called Why Pelvic Pain Hurts. I tend to recommend it to a lot of my patients. It's a quick, 10-minute read in patient-friendly language explaining how the nervous system can become overly wired to detect pain and ways to work on certain aspects to decrease that. And that's why I like to refer to the nosy neighbors. So just because, your endometriosis was confined maybe to your uterus, the neighbors surrounding that might start to also develop widespread pain. And that's something that we work on in physical therapy. And then, like I said, it takes time. Habits can take a long time to break. The brain and perception are key regulators when it comes to pain. And we really do play a large role in getting you to retrain your brain in order to decrease that threat to you, that these are the activities that you like to do, and we're going to find ways for you to move pain-free and enjoy that fulfilling life. Thank you.
Thank you so much, Dr. Wood. And again, incredibly informative. It's now time for a Q&A session. So let's have all of our experts come on camera. And since the top of the mind right now is Dr. Wood's presentation on pelvic health, it almost dawns on me that whether or not it's related to endometriosis or any pain, it's almost like pelvic health is important at every phase of a woman's life, because after you have a baby, you're going to have a whole other set of issues. And as you get older and muscles weaken and the uterus weakens and all that, you'll have another set. So it's almost as if it's important for us women throughout our lives.
Yes, and I agree. I tell a lot of women I am here, and pelvic health physical therapists are here for you throughout your lifespan. So again, after a lot of these major events, whether it be having a baby, menopause, endometriosis, even just a simple hysterectomy not related to endometriosis, we are here as part of your medical team to help return you to the function that you desire and to live a fulfilling life.
And now one of the questions that came for our experts on endometriosis and otherwise, is it possible to go undiagnosed or misdiagnosed for years for endometriosis? Is that common?
Definitely. I see it often too, right? Since there's so much overlap with the bowel symptoms, I've seen it a lot, like we've talked about, diagnosed as IBS, or it presents in a way that it's back pain or butt pain that shoots down your leg. It can very much be misdiagnosed, and a lot of women go undiagnosed or misdiagnosed for a really long time. It could be also something called silent endo, or what we call silent endo, where you don't have pain, but you have endometriosis, which is another thing that can happen. And that's only kind of incidentally found if you're doing surgery for something else.
And then the other thing is the confusion between, do you know if you have adenomyosis or do you have endometriosis? How do you know the differences? other than an X?
Yeah, there's a lot of there's a lot of questions about adenomyosis, so happy you brought that up. I like to think of them as brother and sister. They come together. A lot of the times you can have endometriosis without adenomyosis. You can have adenomyosis without endometriosis, but that's more rare. But I like to think adenomyosis, think of your periods are heavy, you're passing large clots, and you have severe pain with your periods. Endometriosis doesn't necessarily have to cause heavy bleeding, but it causes pain with periods, ovulation, sex, and all those things. There's a lot of overlap between the two. So it's really hard to distinguish, is this adenomyosis, is this endometriosis? If you're having some of both of those symptoms, you probably have both.
Mhm. And Dr. Delgado, you said that you have seen the earliest cases of endometriosis in women in their teens. So my question is, can it happen at any time in a woman's life, even a menopausal woman, if you still have your uterus and ovaries?
Yeah, it can happen at any point. I've had a lot of the times there's this misconception that okay, we just have to get you to menopause and then everything will go away and everything will be better, and that's not the case, right? I've had patients who present postmenopausal, and I've had really young patients present. With the younger patients, it's usually associated with other like congenital syndromes, like if you have a uterus that's a different formation or it wasn't formed correctly, are more common to be associated with endometriosis that early on. But yeah, you can have endometriosis as soon as you start menstruating.
Is it related to fibroids? Can it be familial, hereditary?
Endometriosis is definitely hereditary. There's a component of that. I take a lot of care of a lot of like mom-daughter dyads. Um, But it's not related to fibroids. Fibroids are also genetically driven. Fibroids are going to be, essentially like a growth of your smooth muscle cell of your uterus that causes like a big ball like this of mass that can cause heavy bleeding. And it can also cause pain and pressure. Those are seen with ultrasounds and MRI and different imaging modalities. So fibroids are easier to diagnose than endo because you can actually see it on ultrasound.
Mhm. And Dr. Shane, refresh our memories again as to what the relationship can be between motility and good gut health and leading to any of these other issues of just being a woman.
Great question. So I think that's, certainly top of mind, especially if you've spent any time on social media in the last half a decade. And the tricky part, unfortunately, is many things are packaged in a way that look very convincing and very believable, but there's a lot of misinformation out there. So I always recommend people to work directly with their primary care provider, a registered dietitian, a gastroenterologist, somebody who has direct knowledge in this area. That being said, good gut health informs a lot of chronic health conditions, autoimmune conditions, inflammatory conditions like endometriosis. And so we utilize diet and gut health, which is kind of an umbrella term, as an adjunct for many of these conditions. But like you said, many people suffer from GI distress and really need good guidance. And so it's important, I was giving some general dietary guidance in the some of the questions that were being asked. But we always recommend whole, kind of whole foods, less processed foods. I really dislike the term clean. I think it gives kind of a different connotation. I think it is, gives kind of a moral value to food, which it shouldn't have, right? There's food isn't necessarily clean or dirty. It's more just processed or less processed. And we always recommend less processed foods, things that you can recognize, ingredients that you can read, staying away from non-nutritive sweeteners. So that's like I said, the inulin, sorbitol, all those sugar alcohols that make things low sugar or sugar-free. Many keto items have these in them. So that's something to pay attention to. They can be very inflammatory to the gut, which can trigger many other chronic inflammatory conditions, endometriosis included. Alcohol has been shown to be detrimental to the gut. So moderating the amount of alcohol that you drink, and also what you drink with your alcohol. And then emulsifiers, preservatives, and other ingredients that add no nutritional value to your diet should be used sparingly.
Getting back to the physical therapy part of this, Dr. Wood, Are there better exercises? You talked about Pilates. I'm a Pilates enthusiast myself. Are there others that are better and others that are not so good for any of these conditions we're talking about?
So, when it comes to recommending specific types of exercise, I tend to shy away from saying any particular exercise is super bad or not correct. My goal is to get people staying exercising. So what does that mean? So if someone says to me, I love doing Pilates, I'm going to say, okay, we're going to teach you how to do it with the correct body awareness. So the example might be where it might be bad for endometriosis is if you're someone in the whole hour Pilates class, you're in a Kegel and you're doing that tighten your pelvic floor, tighten your pelvic floor, tighten your core. Teaching someone how to maybe breathe a little bit better through that and having the appropriate amount of tension to the task at hand is what is going to be my goal. Because if that's what they enjoy doing for exercise, it's important for women, especially throughout the phases of life, to stay active and maintain their muscle mass. And so that's why I don't like to say anything's particularly bad. It's just about teaching you how to do it safely and in the most optimal way.
I guess it just dawns on me, running maybe not so good, but I guess if someone is a runner and loves it and that's their form of exercise, that's what you do.
Yeah. And then I'll also say to my patients, look, if the exercise at the time is increasing your symptoms, it might not be forever. It's just for now. We're going to dial back on that and we're going to pull back on that exercise. But let's do some things to prepare you to maybe try and return you to that exercise.
Yeah, pay attention. Let's talk about artificial intelligence, AI. Any technology, wearable devices that endometriosis patients can use? I don't know, Apple Watch or a ring, things like that to even manage their condition?
AI is new for endometriosis. I mean, a lot of research is being done now on AI and endometriosis. A lot of it has been now based on getting an earlier diagnosis and using different algorithms to diagnose patients. For the patient side, I don't know of any devices that will help manage your symptoms, but what I have found helpful is the apps that track your period, and you can track your symptoms with your period. So you can say, "Oh, I have pain today." You mark it on your calendar, and then you're going to notice, "Oh, every month around the 14th of the month, I have pain. That's when I ovulate." And then you can kind of link those things together.
So in
I'd
that
love
way,
to I'd love to piggyback off of that with Dr. Delgado because I do see that with patients who tell me sometimes I'm doing much better from an abdominal pain, diarrhea, constipation perspective. And then when we start to dig in a little more at our next visit, one of the things I'll ask people to track is, well, let's see, is it really, we ask them to keep a food diary. We ask to keep a lot of things. And I also ask them to track their periods. And when we start to notice a correlation, that's when I call in my colleagues from other specialties to make sure that we're not missing a diagnosis.
mhm. And I guess the final question I have, we're running out of time because it's such packed with information, is if your provider is not honoring your symptoms and saying, oh, no, that's not what you have, how do you advocate for yourself? We don't want your symptoms to be dismissed. How do I advocate and say, I need to treat my symptoms? It's not in my head.
Great question. Unfortunately, a lot of patients go through this and are dismissed and are brushed aside by providers. And I'd like to say that with more information we can change this for the provider side, but it hasn't proven, right? I think the best way to advocate for yourself is to educate yourself, right? And to know the symptoms of endometriosis and come to your provider and be like, hey, I have this. This has all been linked to endometriosis. Can you help me work it up, or can you help me treat this? Um, and there are also a lot of endometriosis support groups and help groups online. I know a lot of my patients are really big advocates for these support groups, one of which is in the chat. Hi, Allison. And they really help, like the community of the endometriosis community really helps each other. And they have more insight since they're going through it, right? Since they've gone through it, they have finally found someone that listens. So what made them get to that point, or how did they get there, I think is going to be, I think, the best way to know.
Well, thank you all so much for the privilege of your time, to our experts and for our motivated audience. This has been empowering to women listening and partners also, because knowledge is indeed power. And the more you know, the more education you get, the better you can bring to that provider your symptoms. So on your screen, you can see the women's health experts. You can do the QR code, scan that, so you can get directly to the University of Miami health.org/women's health, and the appointments are on your screen, 855-349-6636 to schedule a consultation. Thank you all for being with us tonight. The audience, you can fill out the survey at the end of this, so give us more topics and some feedback. But I hope you all have a safe night and rest of your week as we get into the close of the week. Have a great night, everyone. Good night.